Hi, good morning, Dr. Garima here. Happy Sunday, and let's just quickly dive into a few of the questions for Australian Dental Council written exam. For those candidates who are appearing in September, I thought I'll just make a short video quickly. I think I'll divide this video into 2 or 3 parts. These are the actual March 2025 questions that were asked, given to me by my candidates. So they could provide me with approximate the same scenario, few options, and then I kind of sat and researched and compiled them with the proper answer and explanation. Let me tell you one thing, it's very highly likely, seeing the pattern of questions that come in the exam, to have a repeat from the immediate exam. So I have seen that the September questions quite a lot are repeated from the March questions, and the following March questions are repeated a lot from the September questions. So knowing what was asked in the previous exam becomes very, very important. So I have made a mock test already and incorporated as many of questions that I could gather from March 2025 exam. And on the concepts on which the questions were asked, I've made more questions so that you are thorough with those concepts. But still, there'll always be new questions and you should always study more about them. So just few of those questions which were asked in 2025 March exam, I'm sharing up here with a proper explanation and answer. I want you all to make notes of this and read more on this subject. Like, don't just study this question, study lateral parts of this questions also. When you open your book where this topic came from, just study the topics above and below it. It's highly likely that questions can be asked from those areas as well, correct? So let's just start, and I've already shared this to all my enrolled candidates on my WhatsApp group, and for you all, I'll just keep sharing as and when I shoot a video. So, case scenario 1. A 32-year-old dentist completes an aerosol generating procedure. Aerosol generating means something which generates a lot of aerosols, basically, like a scaling procedure, for example, on a patient with suspected respiratory infection. Now, when you say suspected respiratory infection, you're not saying it, but it's evident that somehow it's COVID related or some other respiratory infection which is highly infectious, apparently. And you have donned that hazmat suit kind of a thing, full personal protective equipment, PPE. Now, to minimize the risk of self-contamination, and I would say to others as well, what is the most appropriate sequence for removing personal protective equipment? Now, this is given in the infection control book, which is there available online, and it's mentioned on the ADC website as well. Now, they have given the options here, and though it's pretty straightforward and simple, it can get confusing a little bit, because some of us are used to first removing the gloves and then we start removing else. Some of people are focusing on removing the face mask and then they remove the gloves. But always the gloves have to be removed first, because they are the most infected part. Now just imagine, even though you have done a scaling or you have just examined the patient and your gloves are very clean and tidy, but what if they were full of blood? Would you still go ahead and touch your face and remove the face mask with that? No. The first thing is that you will always remove your gloves and incorporate that as a habit also in your clinical practice. As soon as you finish your checkup, and even if you're going to go for a procedure, tend to have a separate pair of gloves. Don't continue with that gloves. It's just to get your habit to maintain absolute sanitization. It's okay to use 3 pairs of glove in the same patient. I do that sometimes, actually many times. I will examine, I will remove, and I'll throw that gloves away, and then I'll make the patient, the parent, comfortable. If I have to take a consent, I'll take a consent with them personally or ask my assistant. But I'll go back on my chair and sit before I start the procedure, giving enough time for my assistant to prepare. But I'll remove the gloves. I won't wear and sit like this, okay? And then when I'm about to start the procedure, at that time I will wear fresh pair of gloves. You understand? So the first thing always you do in any kind of setting is that you remove the gloves and you throw that first. After that, you remove your gown, okay? Then you remove the face shield, and at the end you remove the face mask. This is the sequence, and I want you to write it down. As easy it may sound, as seamless it might be in your clinic, Sometimes when you actually start writing it down and you think of the sequence, you tend to get confused, you know. But when you actually mechanically do it, you are doing it in the right way. But when you start thinking how you do it, sometimes you just mix up the options about it, correct? So my sincere recommendation would be that you just write the sequence and imagine yourself doing it. And remember this example that I gave, that just imagine always that your gloves are heavily soiled with blood. What is the first thing you're going to do? Is you're just going to throw that off. Then the gown, and then the face shield, and then at the last face mask, where you are in the most proximity with your face, thereby minimizing. In fact, I would add on to the point that when you remove your gloves and the gown, you wash your hands, then remove the face shield, and then at the end remove the face mask, and then wash your hands again. Understood? So I've given here an explanation too. You can read it by yourself. Case scenario 2, and this is the second case scenario for the day, which has 3 sub questions to it, and very important topic, extremely important topic. Do expect a question on this always, not just one, at least 3 to 4 questions you will expect, and you will get it. And this is a topic which, as a BDS graduate, you just struggle to understand, because you practically have not examined, treated, or fabricated a splint or understood the disc. I would say you don't have any relationship with the TMJ, you just know the term TMJ, isn't it? And I take myself as one of those idiots who never understood TMJ properly when I finished my graduation, BDS. MDS was a different thing. But you know what happens? Neither the professor who's teaching TMJ tries to make it any simpler by showing us videos. It becomes such a dry subject with very big words like it's a diarthroidal Ginglimo joint, you know, and you have a disc, and you just struggle to imagine how it moves anteriorly, how it has a rotational movement, and then it has a transitional movement. It's so difficult to understand unless a video is being shown to you correctly. So I understand it becomes a very difficult subject to understand, and precisely for that reason I have made a very amazing video on TMJ splints. You can just pause this video, go ahead, watch that video, and come back so you can solve this question properly. And honestly, when I made that video, I myself have said that I had maybe a divine intervention when I was making that video, because I've simplified that into such easy steps to understand. And all the candidates that have watched that video have messaged me personally, like praising heaps of thank yous. They were like, at least we understood. So honestly, that's a good video, you know. I'm not saying just because I've shot it, because honestly that concept clarification was a divine intervention for TMJ at that day. So anyways, you can pause this video, go and search for TMJ and splints Dr. Garima on YouTube, watch that and come back and solve this question. Anyways, we'll proceed. What is the most... okay, I have to read the question first. Okay, this question is tricky, and this is how you're going to get some of the questions. A 30-year-old patient presents to your clinic. 30 is a very important number here. It means a young patient. Okay, 30 is young. Come on, guys. So basically, it's a young patient with a dull ache on the left side of the jaw. Okay, dull ache. It's not a sharp shooting pain. Every word is very important. It's leading you to your diagnosis. For the past 3 or 4 days, okay, the pain began approximately 1 week after receiving a posterior composite restoration. Now this is the trap. They are putting the composite restoration as a trap here. The patient reports no sensitivity to hot and cold. Basically, the restoration is fine, but notices the discomfort while clenching. This is clenching. You may think there is a high point, particularly in the morning. Now see, if there was a high point, he would feel pain on biting every time. It just cannot be only in the morning time. You get my point? And that is why that composite restoration is a trap. Putting 3 lines about it, but then also negating any symptoms about it. You understand my point? So they have put the trap as composite restoration. So you start thinking probably there is a tooth pain or something. But they have said there is no symptoms associated with this. There is no high point. And the patient feels clenching, particularly in the morning. Like I mentioned, if there was a high point, he would have felt pain anytime he bites. On palpation, so you've already done the palpation, there is tenderness over the masseter muscle. This is the masseter muscle. The patient is also under significant academic stress due to upcoming exams. The bold font is my doing. Exam will not give you the bold font. The bold highlighted points are for you to understand the keywords out here. So what you have to take from this question is that there is stress. There is tenderness on the masseter muscle and the patient is young. Why that young patient is important? Because the textbooks mention, and that is what you will observe in your clinics also, the oral myofunctional pain syndrome typically happens in young people. You may say young is beautiful or something. I feel youngness is one of the most stressful period. You have to earn, you have to take care of your family, your children are growing, your parents are there, you're like sandwiched between your children and the parents who are aging, and they have 10 different other things that you have to go through, and you have peer pressure due to various things, and you have a social circle. It's all so difficult to juggle. I'm grateful for all this, and these are all secondary luxury things that I'm talking about. You are, of course, are blessed with the basic necessities, but what I'm trying to say is there is so much of things going on that sometimes you do end up in stress, compared to your child who's playing, doesn't care about anything, and parents have lived their life and now they are chilling, rightly, because they need to. So it's you who's been, having the burden of all the things. So yes, it does get stressful, right, at times. I myself had myofunctional pain syndrome for quite some time. And eventually then when I started my meditation and yoga and started to let go of 1,000 things in my life, I think it just went away, yeah. So anyways, now coming back to this question, you have to ignore the composite restoration part here and focus totally on this. Now, even if you were confused, when you start reading the sub questions, you will understand that this is a DMJ question. Okay, so automatically you leave that composite restoration out of it. Now, what is the most appropriate next step in the clinical evaluation? Clinical evaluation, most appropriate. You know what I'm gonna say. Wherever it's most appropriate, the best option, that means all the options are correct, which further will make your life difficult. You have to choose the most appropriate option. Percussion test on the restored tooth, that is also a correct option, but that is not my immediate next step. Electric pulp testing, palpation of the masseter and the temporalis muscle. Now see, the question has mentioned that you have palpated the masseter muscle, but it does not mention that you have to palpate the temporalis muscle. Now you may say, why am I choosing this option of palpation of the masseter muscle? It's already examined, but you did not examine the temporalis, which is equally important. Temporalis muscle is the phanciate muscle. You have to palpate the masseter and the temporalis, and I would say all the muscles of mastication at that moment. So, bite-wick radiograph to check restoration contact, checking probing depths around the restored tooth. All the options are correct. Nothing is wrong, but my most appropriate next step is I'm going to palpate my temporalis muscle. And since the option also says masseter, even though it's mentioned in the main question, I'm still going to choose that. Get my point? Because my composite restoration is not the problem here. And all the other 4 options are pointing towards composite restoration. The pulp test, the percussion, the bite wing, and the probing. The composite restoration is not the problem here. You get my point? So this is a classic presentation of myofascial pain likely due to bruxism triggered by stress. Palpating the masticatory muscles. Help confirm the source of pain and distinguish it from pulpal or periodontal causes. See what will happen when you go to palpate the temporalis. Maybe it is a lot tender, but the patient is not aware about it. And when you press it and the patient is like, oh yeah, this is the pain I feel. Then you have directly, clearly made the tooth out of the question, correct? And that is why you are supposed to palpate. Question number 2. What would be the most appropriate management option for this patient at this stage? Now, had you chosen some option regarding to composite restoration in question 1, you are likely going to focus on the same in question 2. That means 2 of the questions you're going to mark it wrong. Get my point? But if you would have chosen properly and focusing and understanding that this is myofunctional pain, so my focus has to be to relieve that and not the tooth pain, there is no tooth pain, then you're going to choose the right option. So sometimes in such tricky questions, one question follows the other. And if you make a mistake in the first question, you're going to have a snowball effect and mark all the 5 questions wrong. And then you'll be wondering where I went wrong. This is where you went wrong. You did not understand the question. Understood? So let's go ahead. What would be the most appropriate management? All the options are correct. You have to choose the most appropriate one. Prescribe antibiotics and non-steroidal anti-inflammatory drugs. Replace the existing restoration. Advise occlusal adjustment of the restored tooth. You see how it's coming from the first question. Provide a soft occlusal splint on a night guard and refer to oral surgeon for TMJ imaging. Now here they have given at least 2 options related to TMJ. In the first question they had given only one. See, prescribe antibiotics and NSAIDs is not the right option. If you have to prescribe, you can prescribe a muscle relaxant. Antibiotics, there is no infection. Why are you going to give it? Replace the existing restoration. Why? The restoration is not a problem, right? And that is not what we chose in our first option. First question, basically, the answer of the first question. So that is also out of question. Advise occlusal adjustment. No. Anything related to restoration, we don't care. That is not the problem. Provide a soft occlusal splint or a night guard and refer to oral surgeon. You can be confused between these two. Yes. Now see, when a patient comes to you for the first time and you see that there is nothing urgent or emergency requirement, you can tell the patient that it's wise to have a TMJ consultation. But here they are saying you have to refer to oral surgeon for TMJ imaging. You don't require a TMJ imaging at this juncture. You have to go with the initial steps, which is to release the muscle pain. And that is by giving a occlusal night guard, because sometimes that will just clear the problem off and you won't have to refer. But if that doesn't work for a period of at least a month, then you can refer. You won't directly refer, correct? So you have to provide an occlusal splint or a night guard, and then you have to wait and watch over it. Again, which splint to give, I have made a video on it. Go and watch it. The pain is muscular and related to bruxism. A night guard helps reduce strain on the masticatory muscles for sure. During sleep and prevents further damage. Antibiotics replacement or surgical referral are unnecessarily unless new findings emerge, and with new findings I mean that the previous findings are also not going away. You get my point? Which of the, and the last question now, I think I'm talking a lot. I will get a masseter ache now. Which of the following additional questions would be most helpful? My God, this word most is killing me. Helpful to support your diagnosis. Is the pain triggered by hot or cold drinks? Am I going to ask that? I will be asking that if I suspected a pulpal pain. Does your jaw lock while opening wide? I can ask that. Do you experience this pain more in the morning or evening? Did your bite feel high immediately after restoration? And do you have a clicking sound while chewing? Pain triggered by hot or cold is out of my question. Option B can be correct. Option C can be correct. Option D again related to restoration. I'm just leaving that. Do you have clicking sound when chewing? I won't be taking that option either. If the question said do you have clicking sound while opening the mouth, I would rather consider that option, thinking from a TMJ perspective. You see, all these questions I have to direct towards TMJ. So all the options which are related to the tooth and the restoration are 0 for me. So that actually simplifies me to choose my answer. But still, choosing answer is not that easy as more and more options are coming for TMJ now, right? So I know the question did say that notices discomfort, particularly in the morning, but you still have to confirm. The patient is saying that, but you have to confirm it by asking a proper question. And that is why, do you experience this pain more in the morning or evening, is the right question to ask. And after that, I would say, do you feel clicking? And I would personally check the TMJ area, and then I'm going to ask, does your jaw lock while opening wide, etc., just to make sure if there is any other TMJ problem going on. TMJ is new territory. It's a little complicated territory, but it's not impossible to understand. if you really want to put your heart into it, watch a lot of videos. You know, I even went once to a lecture which was happening here in Dubai, to a TMJ specialist who had a seminar, and he had done arthroscopy kind of a thing. With that camera, he went in the TMJ, and that was the first time ever I saw how the joint actually looks from inside in a live patient, how the discs looks like, how the spaces above and below. And I think it was very interesting. Like, I could not even blink. I was so amazed that this is such an interesting area. And my understanding of TMJ improved a lot after seeing that video. But you, as dental graduates, this idea won't pop up in your mind, so you're not to be blamed. But if you're listening to this video, now you know. I'm guiding you that if you wish to understand, just go on YouTube, watch some arthroscopy videos about the joint, watch a lot of animation videos about the TMJ joint, try to understand how it moves. There are many videos. I mean, this age, so much of information is existing. When I was studying my BDS, I mean, Google and Gmail had just come in, like, and the concept of YouTube wasn't there much. So it was definitely not there, and it was mostly theoretical with pictures, which was difficult to imagine. And plus, you're studying as a graduate, you know, you're focusing more on learning how to extract a tooth, and so much of information was there at that point that the focus is just to clear the exam. TMJ becomes like additional part of it. And because you don't interact much with the postgraduates who themselves don't know much about TMJ unless they do something on it, this topic is pretty much kept on the sidelines. But when you're giving this exam and you're expected to know about all these things, then you have to learn. And learning is good. It will help you empower more in your own clinical practice, right? So, yes, and that's where we end today, and have a nice day. Anybody wants to email me can email me on adcwrittenmocktest@gmail.com. Bye-bye.